but the temperature was maybe 34 or 33. I mean, it was just very cold. And that's got us thinking as to, if we were to set up a newborn transport service, what should we aim for? So this was the first, this is the data from 2012, which we measured in 2013, and we wanted to see how the babies were brought in. And you can see some of them, a lot of them in an incubator. Many of the incubators did not have the temperature settings set, or people were not measuring temperatures. They were simply a means to put a baby in and taking the baby across to another hospital. Many in cots, trolleys, and a lot of babies by hand. People would just bring the babies in hand. And this was the temperature on admission. This is prior to when we started the retrieval service. And you can see that the number of babies, this is 1 year data, 1 year work. The number of babies who were cold on admission were far, far more. Can everybody see it? So 37 and below, a vast number of babies. And this is the common refrain that I hear from a lot of my Sri Lankan colleagues, is we do get babies with very good sort of respiratory support, but babies are being brought in very cold. And if you look at data between the link between hypothermia on admission and mortality, that link is very well established. So babies who are brought in cold to neonatal units have a higher rate of morbidity, and they're more likely to die. So much so that if you start looking at literature, you will struggle to find recent papers on it. It's such an established fact. So we did a lot of information gathering. We went to a lot of the smaller hospitals to understand how they were transporting babies. We saw some units who were very modern in the way they were transporting. They had a transport incubator and everything was set. And there were others who were transporting babies between the radiology department and the neonatal unit in a little plastic tub, and with just some wrapping on. We also found that the ambulance practices were very different. Some of the ambulances had very secure setups, and some of them had very insecure. So you literally had to hold the incubator with your foot, or you had to carry the baby in your arms to bring the baby out. So there was a lot of variation in practice. But we saw one of the transport incubators which was not being used, or not being fully repaired, not fully in use, and we got it fixed on a transport trolley. I'm not sure whether this is still being used, because I think you've upgraded yourself to real fancy stuff. Yes, but this was the first one, and we did some training around how we load babies into ambulances, how we take them off, how do we maintain, how do we ensure that the babies inside the ambulance are secure. We worked on checklists. We created a small team at Lady Ridgeway Hospital where the unit nurses and doctors created their own checklists from what we had from Oxford. So they modified it for their own use, which I think is very important. It's very important to do what is very bespoke and very particular and very peculiar to your own circumstances. Now, in your manuals, at the back of the manual, the Appendix 2 and Appendix 1, you will have a lot of templates. Some of them are from Oxford, many of them are from London. Is all the checklists and all the sheets, all the observation charts that we've printed. Please feel free to modify them to your own use. Again, I would say this is not something which is rocket science. It's all intuitive, but it's there for you to modify and use. So that started, and when we reviewed the data after we set up the transport service, this is what we found. This was just the demographics, but this is the graph. I think this is the chart that I want people to remember as to what can be achieved in a year by using simple things, which is focus only on temperature and blood sugar. So if you look at the blue bar that represents babies who were transferred into Lady Ridgeway using the retrieval service. The red ones are the ones which are non-retrieved. On the x-axis, you can see the temperature. Is everybody able to understand that graph? And you can see the number of babies who had temperature in the normal range was huge. In fact, if you look at the cut in hypothermia, it was more than 50% reduction in the number of babies who were cold. And this is at the receiving end, so this is the end of the transport, not at the beginning of the transport, this is the end of the transport. And the ones which had not been retrieved, a sample of those babies showed that the temperature varied from 33 right up to 37, 38 plus. So some of them were even were overheated. And I think that is what I would remember as something which was achieved. There was not a single infant who was retrieved and had a blood sugar of less than 45. So all these babies had normal blood sugars. Is it something great? Yes, it is, I think, because we managed to demonstrate that within a year, using simple mechanisms, we've been able to cut the rate of hypothermia and rate of hypoglycemia. And it's not been easy, because mind you, this was not the UK, where we have a lot of nurses. The number of nurses in every hospital, I believe, in Sri Lanka is limited. These nurses are looking after your babies. They're also being co-opted to transfer. The same thing goes for medical staff. You've got medical officers who are working in small centers, who are managing the neonatal unit and managing the children's ward as well, but are also engaging in newborn transport as and when required. So there is a huge resource pressure on everyone doing this work. So it's not easy, and there is difficulties in uniformity. There is difficulty in getting equipment, and when the equipment is there is no standardization. So you could go from one hospital in one province to the other and you'll find different equipment. So there are lots of factors, but I think it's very easy to get bogged down by problems, and you can think, oh, there are so many problems, and what should we do? And I think this small project just demonstrated that despite these issues, there were some real important outcomes that could be achieved by simple steps. I think that is the first step on improving your newborn transport, and since then I think we've gone from strength to strength, and hopefully as time passes we add more and more quality measures as time passes. But this is what is achievable. So that's what I wanted to start the day with, is just to instill a sense of confidence in the people here who are either providing newborn transport service on their own or will be training doctors and nurses, that this is very much an achievable target. This is not something which requires a huge amount of sophistication. It requires a lot of planning, thinking. Of course it requires resources, but it's not unachievable. So what are we going to do during the day? As Ramya mentioned, that this is a workshop for trainers as much as for people who, some of you have attended this before. And so what we would like to do as a team is to make it much more useful for you. And it has to be driven somewhat from your questions and your needs. So please do not be reticent and ask lots of questions, because that's crucial. The couple of things as take-home messages that we would like to take for this audience to take home is, so what do you want to do at the end of the day? At the end of the day, I think we would like to reinforce that using checklists, using a planned system of transfer, and thinking ahead and planning is crucial. That's number one. Number two, gone are the days when you scoop a baby and run. And we shouldn't be doing that. You should think and manage the babies best where they are. It's often babies who get scoped and taken to larger hospitals have poorer morbidity, because we fail to understand that even when we are in a small hospital, we can provide the baby stabilization and get the baby in better condition to have the transfer. So of course when you're anxious, as a clinician, what you want to do is get the problem out from your hands, because that's one of the basic instincts. This baby's sick, I want him somewhere else. But it is spending the time and effort to understand that it's valuable to get the baby stabilized before you transfer. So this is the second thing which I want for people to understand. And the third thing is about teamwork, where teamwork is a very big word. Who knows what it means for different people? But it is also to do with breaking of hierarchies, because we all working in some kind of hierarchical system. But when you are out there as a team, on the road or in a different hospital, you must try and must cut down the hierarchies between doctors and nurses, so that we all work and complement each other. So those are the three things that I think I would like people to remember and take forwards. And in the structure of the day, we're going to reinforce that repeatedly. So much so that you will, when you wake up at the middle of the night, that's all you will think about. So we want to just reinforce the same thing, the accept model, doing checklists, and making sure you organize your transfer. So I'll now ask Dr. Naviran to take the next lecture. And following this, we will break into 3 teams or 4 teams. We've got 3. Have you been split into 3? 4. Fine. So that's perfect, because we'll have 10 to 12 people in one team, and that will give us concentrated time with you folks. Over to Nandan. Thank you.
Good morning, everybody. Thank you very much, Amit. Thank you very much for the invitation, Rami, and the opportunity to assist with some of the project relating to provision of neonatal transport in Sri Lanka. Very grateful for the opportunity. So I'm Nandan Ratnavel. I'm a neonatologist. I work at a neonatal surgical referral centre in London, the Royal London Hospital, and our hospital hosts the neonatal transfer service for London, and we retrieve patients from about 30 or so different hospitals, and we have a mixture of basic, middle and intensive care units that we move patients between. So the remit of this first session from me is to reinforce the ACCEPT acronym and to provide you with a structured approach for neonatal transfer. And I think the trick here is for us to recognize that we have many learnt behaviors as experienced clinicians, doctors and nurses, things that we're used to doing in certain ways. And sometimes challenges arise when our plan of care for a patient or for a process differs from the plan of care of our neighbour, and the fact that we don't necessarily see the priorities in the same way can lead to conflict, misunderstanding, and in the worst case scenario, an adverse event on the actual patient. So we need to collate our thoughts around the processes involved in transportation, because the concept of putting a patient in an ambulance and taking it to another hospital is a very simple one, but it's a very fragile patient, and the flaws and pitfalls are many, so it's important that we get that simple step correct. So the first thing I think I appreciated as a neonatal transport clinician versus being a neonatologist was that the transport environment posed unique problems, and I do think it's a mistake to just assume that one's neonatal practice can be transmitted into motion, into a vehicle, into the external environment, into another hospital, dealing with different members of staff. So it's important for us to be aware of the additional challenges that transport imposes. So variations in environmental temperature that are going to affect the infant and are going to affect their staff as well. The physical forces associated with vehicular movement, acceleration, deceleration, vibration, and that's just road transport. We're not really going to talk about air transport, but that provides even more challenge. the fact that as a clinical team you are relatively isolated. You will obviously have your kit bags, but you don't have a storeroom full of spare equipment, and your source of help and advice from your senior may not be immediately to hand. It may be by phone, but they're certainly not going to be by your side all of the time. That core team needs to be competent and needs to communicate with each other very effectively. The back of an ambulance is not a good place to do intensive care. It makes for an interesting story to tell people about the chest drain that one inserted or the re-intubation that one did by the side of the road, but and that can sound very heroic to people that aren't involved, but it's actually very unfortunate for the patient and is going to rack up the morbidity and mortality rates significantly. So it's all about stabilising pre-transfer. And what we have seen in the UK, and I think Amit's slide regarding the temperature shows us that you're seeing the same thing here, is that neonates and children transferred by trained personnel do complete the transfer in better condition, and that there are fewer transport-related adverse events. And whether that's related to better outcomes is another piece of work, but that may be true as well. As far as the patient is concerned, the baby doesn't really care who it's being cared for by, as long as it's receiving the highest quality of care, and the parents should have that expectation as well. So whether the baby's in a smaller unit, in an ambulance, or in a receiving unit, the plan of care for that baby should be agreed by all the relevant parties and the best standard of care delivered to that baby. So the treatment modalities of the intensive care unit should be transferred to the referring hospital, where that level of care can be established as much as the local resource allows, and then that care can be continued during the transfer to the receiving facility. And we achieve that by good communication, by agreeing contracts of care between the transport team and the local referrer as to how that baby should be managed before the transport team even arrive. What the transport team then do locally, and then moving finally to the definitive care centre, which is where the specialist treatment will continue. A transfer service may be referred a number of calls simultaneously. It's certainly very common in my service, and we need to be able to triage those referrals and categorise them according to the clinical acuity of the patient, but also the resource level available at the local hospital. We need to be able to provide ongoing advice that concurs with the specialist unit that the baby is going to. I think certainly when you're an independent transfer service that is taking babies into a number of different specialist units, you want to make sure that the advice you're giving the referring clinician concurs with the advice that that specialist hospital would also give, because if that advice is conflicting to the referrer, it's not particularly helpful. And that advice will include agreements on how to go about the resuscitation, what level of stabilisation is required pre-transfer. The transfer team will continue that during the transfer, hand over to another team at the receiving hospital, and that's the transport episode over, done as best as it can be. But we only get better at this by constantly training, by doing simulation training, by being open to feedback on suboptimal performance during transfer, and by doing outreach education to our smaller hospitals. So it's not just the standard of the team, its transfer team itself, but the standard of the referring hospital practice and the receiving unit, and everybody's game goes up. So we need organisational and management strategies to how transport is delivered, both for the acute transfer and for the service in general. And we also need practical solutions to practical problems, such as what is it that constitutes preparation of the patient, preparation of the equipment, preparation of the vehicle, preparation of the team. What is it that's important when one is packaging up a patient in advance of moving them into the transport incubator, such that the endotracheal tube does not come out, the umbilical lines do not dislodge, the chest drain does not fall away. and the actual transportation itself. So speed is not necessarily the answer, and we need to have good dialogue with our ambulance services and our drivers as to what's the best mode of transporting the baby and the best manner of transferring the baby such that physiology can be maintained. So we use this ACCEPT acronym, which is taken from the Pediatric and Neonatal Safe Transfer and Retrieval course run by the Advanced Life Support Group. And it is not the only way, but it is one way of structuring the transport process such that as few adverse events happen, and it's a safe way. So the ACCEPT acronym can be applied to different stages of the transfer, and we'll talk about the different stages. But the basic acronym is this: assessment, control, communication, evaluation of the situation, preparation, packaging, pre-departure checks, and then the final actual transport. But this ACCEPT acronym is applied slightly differently depending on which stage of the transfer you are at. But when you get well practiced, it becomes subconscious. So the assessment of the ACCEPT is an assessment of the problem. What is the problem that this team is being faced with? What's being done about it? What effect have those treatments had on the baby? And what is now needed for the baby? For example, if you're a referrer, you may say, okay, I have a 26-week gestation baby. The primary problem is respiratory distress syndrome and hypotension. That's the problem. What have I done about it? Well, I've intubated and ventilated the baby. I've given surfactant. I've got a vascular access. I've given a saline bolus. That's what I've done to treat those problems. What effect is it happening? Well, the baby's oxygen requirement has come down, the blood gases have improved, the blood pressure has come up, but is going down again. So what is needed now in terms of ventilator strategies, inotropes, etc.? So it's just structuring the assessment of the problem rather than approaching it with an attitude of, there is a problem, I just need to move the patient. I need to address the problems first and then move the patient. So that's the assessment concept. The C in ACCEPT is getting control. So that control is a number of things. It's control relating to the patient, equipment, organisation. So these are just some of those things. Identifying a transfer team, I say leader, but it doesn't necessarily need to be a leader in terms of seniority. It needs to be somebody who's effective at coordinating the transfer and identifying the transfer tasks. So who needs to be spoken to? What are the communication issues? Who do we need on this transfer? Who are the personnel relevant? What equipment do we need for this specific move? Do we have adequate supplies? Have the checks been done for the morning? Do we have enough of everything? Are the gas cylinders full, etc.? And it's very important, I think, rather when you've identified what the tasks are, not to just spread out and assume that you're going to be doing them as a group, but allocate tasks to individuals or teams, so everyone knows their responsibility. Giving pre-transport advice is really important, and I think we'll be practicing this in some of the workshops. So you'll be taking a referral as a receiving unit or a transport clinician, and taking that referral is not just for you to get the information that you need, but it's for you to say to the referrer, I need you between now and our arrival in 2 hours' time to do A, B, C, and D. And that will improve the outcome and the impact on the patient. And the presence of a transfer team is almost secondary because the plan of care for the baby is already being implemented. Getting control of equipment. So is it appropriate for transfer use? Do we have enough of it? And pre-departure checklists are very much part of that. It's very easy to grab your kit bag that has not been checked and signed for, only to find essential pieces of equipment are not present. That's a reality of very experienced transfer teams, and it will almost certainly be the reality of new transfer teams evolving their practice. There are bigger organisational issues that need to be addressed about the weight of the transport incubator rig and how it's fixed into the ambulance. That are more kind of system-based organisational challenges. it's important that the team are familiar with the equipment. And I can confess to you that certainly in the early days I have done many transfers where I may not have been completely familiar with how that incubator worked, how that ventilator worked. And I think it's very important, although nurses and doctors and equipment technicians will have their responsibilities, that as a group we all know to a greater or lesser extent how everything works. And then fixing it safely within the transfer vehicle. Road traffic accidents are not common, but when they do occur, and you have a 250 kilogram transport incubator rig secured improperly to an ambulance, the impact of that is devastating. So it's very important to address those things. Getting control is control of getting the right people on the transfer team. Are they appropriately trained and skilled? Have they had their transport competencies measured? And in your books you will have some information on what we expect a transport competent clinician, whether that be a doctor, a nurse, a paramedic, etc., to have. They should be able to operate in a transport environment, simple things like sickness, motion sickness. They should be appropriately equipped and clothed. And certainly for us, at some point we did have to address additional accident policy insurance cover for staff that were regularly going out in ambulances, that was over and above the insurance that covered them for their hospital practice. Who communicates with whom? That's the C in communication. Well, there are so many people that need to be involved. The referring staff, for one, who are presenting you with the baby, ambulance service personnel, other transfer team members within your team, your base hospital, the receiving unit, the parents, will all have slightly different expectations, and the need for transfer may have come about very, very all of a sudden. So it's important to get everybody in the loop. What needs to be communicated? I know I'm stating the obvious here, and please forgive me for that, but only last week I picked up the phone at our transport base from a clinician who simply said, "Hello, it's Dr. So-and-so, I'm ringing from the neonatal unit." The neonatal unit could have been one of 30. So it's just very simple things. "My name is so-and-so, I'm calling from Lady Ridgeway Hospital, the phone number is this, if you need to get back to me if our communication gets cut off." And then back to the assessment bits. What is needed? What do I need from you? So from the listener, it's very important to hear what this person wants. Do they want advice? Are they requesting a transport? Do they need you to find a bed? It could be a number of things. It could be all of those things. What are the relevant patient details? And then the problem. What's the problem? What's been done to address the problem? How has the patient responded? And what do we now need to do for the patient before we effect the actual transfer? Record it all, write it all down, because people will often say to you, "Oh, this person didn't say this, I was not advised this, they may have advised a ventilator change but gotten it wrong." So record all the communication and any subsequent follow-up calls that you may make. And we're really emphasising the idea of communication here because it's so important to have an open mind, to listen, to talk to your team, explain why you're doing what you're doing, because I think if you have the motivation of your other team members behind you when you're planning care, they will be a lot more cooperative. Use the local expertise. Do not assume when you swoop in to rescue a baby that the local hospital are no longer relevant. It's their unit, they know where equipment is, they know how to access what they need to access, they know the parents, they know the baby. So use the local expertise, and it fosters better relationships for subsequent transfers, which you will do. And at all times, be diplomatic. So the accept, E in accept for evaluation is recognising the need for transfer, agreeing that the patient needs to be moved, and then the transfer category in terms of level of urgency. Is this time critical? Is this urgent but not time critical? Is this a repatriation, etc. Preparation and packaging could be a number of things depending on what stage of the transfer you are again. Whether you're at the beginning, en route to the baby, whether you're at the referring hospital with the infant, or whether you've actually completed the journey and you're going back to base. So preparation could be of the patient. It could be the clinical preparation of the patient when you're on scene. It could be the preparation of your equipment prior to departing your base. It could be the collecting of all your equipment and documentation at the end of the transfer. Packaging up the patient means packaging the infant safely in the transport incubator, safely in the vehicle. It means packaging up your equipment. Pre-departure checks, absolutely mandatory. I think those are an absolute must. They prevent you from leaving equipment behind, from forgetting important tasks. And then the final physical transportation. So those are that's broadly what accept means. The setting, I've said, varies. So accept can be applied at different stages. Stage one is this: from the initial referral coming in up to arriving at the referring hospital. So you haven't seen the patient yet, but in that time you've taken a referral and assessed the patient from the information that you've been given over the telephone. You need to acquire control in that you need to get the right staff, you need to get the correct equipment, you need to get the vehicle organised, you need to communicate effectively and make sure you've got the right documentation prior to arriving at the referring unit. You need to evaluate the level of urgency of the transfer and where it's going to. Is this a cardiac case? Is this a respiratory case? And it may be that the destination for the baby that you've been referred is not appropriate. It might be that that specialism is not available because there's something in the clinical story that you've hooked onto that makes you think, actually, this doesn't sound like what the referrer thinks it is. So evaluating that sort of thing, preparing the equipment and the vehicle, making sure everything is safely stowed away, and then transporting yourself during the journey to the referring hospital, and we'll talk a bit more about the manner of that. Stage two is when you're actually there. So you've arrived at the referring hospital, at that point assessment means something slightly different. Is there anything new that's cropped up in terms of the patient condition or the bed availability or the staff, any new issues relating to the patient or the transfer needs? Getting control here is really important. So it's about delegating the tasks, having received handover, that this baby now needs, assessing, prioritising the tasks for the infant and delegating them to different individuals. So you don't assume that this is the order of play. You may think the ventilation adjustments are the most important thing. The nurse may think the circulatory status needs addressing. Somebody else may find the baby very cold. And you all will have the same priorities, but in a different order. So it's important for you to understand what the priorities are and who is going to deal with what. So everyone works in parallel rather than a series of tasks being done one after the other. I think it's really important to actually establish an estimated time of departure for your team. So having decided on what the priorities are and allocated the tasks, you can make a reasonable educated guess, because you're experienced clinicians,